feel really honored that Dr. Bruce Perry is able to share with us some of the advances in our understanding of really the factors how trauma may affect and does affect the developing brain and its implications for clinical work. You know, Dr. Perry has a very, very extensive, very impressive, you know, resume. You know, he's been a teacher, a clinician. He's been a researcher in neuroscience and this area of trauma in children. And he's written some best-selling books as well, and some of you may have read them or heard of them. The Boy Who Was Raised as a Dog and Born for Love, Why Empathy is Essential and Endangered. So we are so pleased that Dr. Perry will share with us what the state-of-the-art information we have about the impact of trauma on a young brain and how that influences emotional functioning and behavior, and the implications for all the hard work that you guys do out there as clinicians in working with children and their families who have been affected by traumatic life experiences. So I'm going to turn this over now to Dr. Perry, welcoming him, and thanks very much, Dr. Perry, for sharing your knowledge with us during this Lunch and Learn webinar.
Well, first of all, thank you very much for asking me. I appreciate the opportunity. I am always a little bit intimidated by trying to talk about the wide range of topics that have relevance for clinical work with individuals who've been impacted by trauma. And I think, as all of you know, this area is huge, ranging from trying to understand mechanisms of transgenerational trauma to understanding the impact of developmental trauma on adult functioning, to understanding, what are the best clinical practices to use when you're working with children and youth who've been impacted by trauma. And then, of course, there's a range of issues related to diagnosis. I'll mention a little bit about some of the confusion in that area. But I really think that what I'm going to do for the next, I'd say, 45 minutes or so is talk a little bit about some of the biology that underlies the stress response and how the stress response and the brain can be influenced by experience. Experiences that are either negative or experiences that are potentially positive. And this will hopefully give you some insights about both vulnerability and resilience, and potentially some useful insights about some of the mechanisms that may be related to therapeutic interventions and change in individuals who've been impacted by trauma. So, and again, any presentation always has sort of a little bit of a bias. My bias is, and perspective is going to be a little bit heavy on the neurobiology. I don't want people to be too intimidated by that. It's something that is understandable, and there are lots of core concepts about how the brain works and changes that are easy to understand once you know some of the basics. So I'm going to do a few of the basics, and then we'll get on to some of the more complicated stuff. In the meantime, I just want to remind you that you have the option to enter questions, type questions in along the way, and we'll collect those and sort through those. And so in the last 10 minutes or so of the presentation, we can go through some of those questions and get them answered. All right, so here's the bottom line. When we think about human behavior, human beings, just because of my neuroscience bias, I always think about the brain and what's going on in the brain when you are experiencing any aspect of life. What's going on in the brain as it develops, what happens in the brain when you're in a therapeutic interaction with somebody, what's going on in the brain when you are being yelled at by your parent, what goes on in the brain when you are witnessing your parent, one parent beat another parent, or any other variation of developmental adversity. And obviously, this little picture shows a couple things about the brain. One is that it's got a lot of different parts, and that is something that I'll come back and revisit in a minute. But I want you to remember that the brain isn't just a black box. The brain is a collection of neural networks working together under ideal circumstances in a somewhat seamless way to create a range of capabilities, from thinking to feeling to moving. And one of the things we always try to remind people is that the brain and all of its organization, all of its functional capabilities, are essentially the product of evolving in a different world, very different than the modern world. And so in the world for which the brain is optimally organized is much less sensory busy than the modern world. It has far fewer auditory and visual stimuli that are what I would call artificial. There's less traffic. There was no traffic noise. There was no nonstop visual presentation of screens. There was no background music when you were shopping or hunting. There was a whole different soundtrack to the way our brain, in the world in which our brain developed. And one of the most important things for trauma and understanding both resilience in the face of trauma and recovery after trauma is recognizing that the brain is a social organ, that human beings are neurobiologically organized to be part of a larger clan or group, and that if you look at any part of the brain, it is influenced by or involved in some aspect of connecting with other people. Either, you can look at the way our sensory apparatus are put together, the visual nuances that we pay attention to in someone's facial expression, the fact that we're incredibly sensitive to touch, the smells that influence how our brain is regulated, the sounds that we actually perceive. All of these things are essentially biased towards human social interactions. And the milieu that we grew up in was much, much more relationally dense than the milieu that we now live in. And one of the consequences, and many of you may know a lot about this, but one of the consequences of this relational neurobiology is that human beings are more physiologically regulated in the presence of lots of safe and familiar people. And when they are in a social environment that's fragmented, when they're disconnected from community, from neighbors, from extended family, it puts a bigger burden on their stress response systems. And so I'll come back and talk about this in more detail in a minute, but the bottom line is this. If you want to walk away from this, this 45-minute presentation with something useful, the most useful thing I think you can probably get is that people in dense and healthy relational environments are much easier to work with clinically. They benefit from our interventions more effectively. And individuals who are in relationally impoverished environments, disconnected from after-school programs, multiple placements, they've got kicked out of one school, go to another school, they've got no extended family involved in their life. That form of relational isolation makes anybody, independent of their history of adversity, much more vulnerable to trauma-related, stress-related, physical, emotional, and cognitive problems. And I'll come back and, we'll touch on that again in a minute. And again, I'm not saying anything that most of you probably haven't observed. So this slide illustrates some of the aspects of how the brain is organized. Now, obviously, this is an oversimplification of the brain, but you can categorize the brain into 4 larger areas, and they're organized from bottom to top in a hierarchical fashion such that the lower parts of the brain are structurally more simple, and the top parts of the brain tend to be structurally more complex. And if you look at the functions that are broadly mediated by those parts of the brain, you can see that the functions increase in complexity as you go from the bottom to the top as well. So the characteristics of being a human, the things that we identify as most human, language, abstract cognition, future planning, all of those things are mediated in large part by the top part of the brain. And then the lower parts of the brain are, the networks down there are more involved in what we would consider regulatory functions, influencing heart rate, blood pressure, and so forth. Now, your brain is continually processing input from the body and input from the outside world. And I'll talk about that again in a second, but because all of this incoming information comes into the brain low, there is a first step in the sequential processing of information. And that first step occurs low in the brain. Now, it just so happens that the brain got these, I'm trying to use my eraser function, I guess it doesn't work. The brain has a set of very important, widely distributed regulatory neurotransmitter networks, and you all have probably heard of them. You've heard of norepinephrine and serotonin and dopamine. These are some, but not all, of these important, widely distributed regulatory networks. Now, the reason this is important is that because these neural networks send connections out into all different parts of the brain, what will happen is you can actually have simultaneous communication with multiple parts of the brain at the same time. And this marvelous microarchitecture that allows us to weave together all of the separate parts of the brain and all these different networks and get them working together is facilitated by these primary regulatory networks. So these cells, even though they're relatively few compared to all the other neurons in the brain, have a disproportionate power in influencing how the brain functions. And so this is a great gift. This gift allows us to take 85 billion separate moving parts, you know, that's the number of neurons you have in your brain, and get them to all work together. And when they work together, you can actually have a thought that gets turned into an action in a seamless way. You can actually perceive, wow, I'm thirsty, so I'm going to get up and go to the refrigerator and get something to drink. And so you can have this continuous flow of adaptive behavior that in human beings can get incredibly complex, as you all know. You can have a thought, you can create, you can fall in love, you can make a plan about how to actually act on the fact that you fell in love, and so forth. And all of those seemingly smoothly integrated functions are mediated by literally hundreds of different separate networks, but woven together by these primary regulatory networks. Now, the reason I'm going on and on and on about that is that these neural networks, when they develop normally, will allow these great functions. But anything that compromises the functioning or regulation of these networks, anything that disrupts the normal development of these networks, is going to have consequences for all of the target areas that these networks influence. And as I said earlier, because of this crucial microarchitecture, these networks influence the parts of the brain involved in cognition. They influence the parts of the brain involved in emotional and attachment behaviors. They influence fine motor control and sleep and attention. And they influence outflow of the autonomic nervous system and the neuroendocrine systems out to the body. And so you all know, you probably are familiar with the ACE studies, which are epidemiological studies that have looked at the relationship between adversity in childhood and physical health problems. So if you dysregulate these stress response networks and impact all of their outflow and their influence on outflow to the body, the immune system, the neuroendocrine system, the autonomic nervous system, you'll get dysregulation in the heart, dysregulation in the lungs, dysregulation in the skin, dysregulation in the pancreas, and you get heart disease, diabetes, vulnerability to all sorts of things. But more importantly for our field, what happens is, I probably shouldn't say more importantly, what we know is that if you have anything that causes an insult for those neural networks, you're going to get a cascade of problems in all parts of the brain that are influenced by these networks. And I know this is kind of messy, this slide, but I think you can appreciate that if these neural networks are disrupted, you have a host of problems. Now, three things we know will very predictably cause these problems. Intrauterine insults, such as alcohol or intrauterine substance abuse. Perinatal attachment disruptions, and again, I'm sure you all know that the primary caregiving experiences are essentially stress response system organizing experiences. Infants can't self-regulate very well. They can't, so they depend upon external regulation. But if that external regulator is in an abusive relationship or depressed or absent or high, the pattern of relieving the stress of hunger, thirst, and cold is going to be inconsistent and cause problems. So those are the two of the ways in which you can disrupt these primary regulatory networks: intrauterine insult, perinatal attachment problems, and then trauma, neglect, adversity as you get older. So you all know about childhood trauma, and you know that that influences the stress response system, and you know that that's really mediated by these neural networks. And so it's no surprise then that developmental trauma becomes kind of the great imposter for mental health clinicians. You can have a child who looks like and meets criterion for ADHD, but it very well may be related to developmental trauma. You can have children who meet criterion for many of our traditional DSM-4 and now DSM-5 diagnoses, but in fact the origin of their problems is developmental trauma. And this confuses our field. And, you know, as you all know, it's not unusual to see a child in the child welfare system end up with 5, 6, 7 different diagnoses, and then have those change as they're assessed when they're 5 versus when they're 7 versus when they're 9. And again, our field is just beginning to come to grips with some of this stuff. So the interesting thing about this is that the very systems that make you dysfunctional are the systems that you need to activate and recruit to make you healthy. And again, I'll talk about that in a minute, but I would like to emphasize the fact that stress in and of itself is not bad for you. In fact, stress is actually crucial for normal development. Stress is a component and a positive component of normal learning. And stress, when it is present in an appropriate pattern, actually is what leads to resilience. People become more resilient by having moderate, somewhat controllable challenges. and that makes you more resilient to future stressors. But when you have unpredictable, severe, or prolonged activation of those networks that I just talked about, you end up with vulnerability, and that manifests in the ways that I showed earlier, in the ways we all see. And so there's two concepts that are neurobiological concepts that are, I think, helpful in understanding therapeutic efficacy for any of our trauma-informed interventions. And also the same concept helps you understand a little bit about the origins of some of the stress-related problems. So I'm going to talk for a second about sensitization and tolerance. And again, this is a little bit of a neuroscience-y set of concepts. I think they're kind of familiar to most of you, but let me just walk through this very quickly and bring a little clarity to why stress is not the core problem. It's the pattern of stress that ends up becoming probably the most important variable in understanding these issues. So if you have a certain stimulus, you put a certain challenge on someone's stress response system, they're going to have an activation of their stress response systems, and there's going to be a certain duration of that response. And if you wait for 2 weeks and you come back and you give the same stimulus, you're going to get the same response. And you wait for another 2 weeks, same thing. However, if you take somebody and they have a significant stressor and they have a response that's proportional to that stressor, and then before they've had a chance to get back down to their baseline, there's another stressor, and then another stressor. And they can be of different sorts, or they can be related to the same event. And so one of the things that you see following a trauma, for example, is, and again, let's take the shootings at Newtown. Let's say that you were on site when that happened. Before you even have a chance to get back to your baseline, you're going to see a news report. You're going to see a friend of yours who was also impacted by that. You're going to wake up the next morning and drive by the school and have a reminder. And so what happens is, even though you are not actually in a life-threatening situation any longer, the fact is that there are all kinds of reminders that are going to cause, in an unpredictable way, reactivation of your stress response system. And this, all of you who know about the post-traumatic experience, you can see where the uncontrollability of how that you revisit that can lead to this sensitizing pattern. Now, what happens is when somebody has a sensitizing pattern of activation of their stress response system, their baseline over time, their baseline level goes up. In other words, they get more tuned up. And their response to a moderate stressor is much more extreme. So that's why we use the term sensitized. And so for the very same provocative stimulus, they'll have a dramatic overreaction. Now, the opposite of that is tolerance. And that is that you can actually have a stressor that's pretty significant. And then over time, if you have multiple controllable, predictable little doses of that, you end up actually having your baseline go down, and rather than becoming sensitized, you become resilient. And so those of you who know about certain kinds of desensitization paradigms in mental health, this is the neurobiological principle that they're tapping into. And many of you can see that trauma-focused cognitive behavioral therapy, when it is applied to someone who's ready to do that, will result in a decrease in their baseline level of arousal, and their sensitivity to evocative cues will shift. And so again, you can take somebody who's developed a sensitized stress response system from being having some sort of traumatic experience like a school shooting or a other form of specific event. And if you give them opportunities for revisiting that event in a controllable, digestible fashion, you can see their baseline level of arousal decrease. And this will manifest in a lot of different ways. You can measure their anxiety, it will change. You can measure their heart rate, it'll change. You can measure their physiological reactivity, and it will improve. So this phenomenon underlies a positive response to a therapeutic intervention. Now, there's a couple of things that are important here. One is that the dosing needs to be different than a traditional model that we're used to. I mean, I think most of you know that when you think about something that's overwhelming and intimate and that's been hard for you, you don't usually dwell in that for 45 minutes nonstop once a week. It pops into your head a lot, or you think about it a lot. Let's say you're worried about a partner who's got breast cancer, and you don't know you have no controllability over that. And you want to no longer be ruminating about it. You don't want to worry about it, but it wakes you up at night, and you think about it during the day, and all kinds of things cue you into having that fear. There are ways to actually have doses where you schedule when you think about it for 3 to 5 minutes, and when you take control of how you revisit that set of fears about your partner's breast cancer, you no longer are as sensitized. But if you just let the random thoughts pop into your head and you are completely responsive to random evocative cues, it's very hard to get better. And so I'll talk more about neuroplasticity and these two patterns in a minute. But let me just move on to this slide and show you that the consequence of this sensitization is that you change the normal linear relationship between external stressor, which we all have, and internal response. And so most of us wake up in the morning, safe and familiar environment. We can be in this active alert state. And then we go to work, and it's really icy, and we live in Atlanta, and we swerve around, and we play bumper car on the freeway, and we get into these alarm states. But the truth is, the people who played bumper car in Atlanta, they're not going to end up with long-term trauma, most of them. Most of them are just going to be really anxious when they were sliding around and ready to hit somebody. And then a couple days later, they're going to go back down, and they'll be at their baseline. Now, they may not like to drive in snow anymore. They may be sensitized to that specific phenomenon, but it's highly unlikely they're going to end up with, traditional trauma-related stuff. In contrast, somebody who has this permeating pattern of chaos and threat. Let's imagine a little child growing up in a domestic violence environment, or with a mom who's in and out of struggling with substance abuse. There's a tremendous amount of unpredictability about when the child is fed, when the child is not fed, when they go to bed, when somebody comes in and yells at mom. And the chaos leads to this sensitizing pattern of activation of the stress response, and there are lots of consequences to that. One of the most significant consequences is it changes the window for either, we call this the learning window, you can call it the therapeutic window, but the fact is that the brain only changes when it's exposed to novel cues. Because if it's exposed to familiar cues, that's already been internalized. So to learn anything new, you have to be exposed to novelty. Novelty in and of itself activates the stress response. And so the key is this Goldilocks effect. You want to have just enough challenge, but not too much, because if you have so much challenge over here, what happens is you start to get overwhelmed and you shut down the parts of your brain that you're wanting to change. So there's a state-dependent capacity to optimally change, to optimally learn. And this is true if you're learning a motor skill, a cognitive skill, an emotional skill, and so forth. But the downside of becoming traumatized is that you lose the normal linearity between external challenge and internal response. So if you have this sensitized stress response system, like many of these kids, youth, and adults do, you can barely tolerate any kind of transition or any kind of novelty before you get into this state where you're completely dysregulated. And so for a school-age child, the consequence is this. Even though they may be in a really good school and getting exposed to all kinds of good teaching, their brain is not capable of absorbing it as efficiently as a child who's well regulated. And what the challenge here is that what therapeutic work needs to do is to change the slope of this curve. So you need to help these dysregulated systems become better regulated. And again, I'll touch on that in a minute. But again, the downside of having a stress response system that's so tuned up like that, like this red line, is that you can be in a really decent school, and after 1 year of academic content, you'll be half a year behind. And after 2 years, you'll be a full year behind. And so these children fall behind academically. And actually, those of you who have been keeping track of the new thinking about the achievement gap, you will recognize what I'm talking about. The achievement gap is literally about kids coming to school in a state of higher distress. And that distress could be from hunger, chaos, community violence, all kinds of stuff. But it's not because of the color of their skin. It's because of the character and nature of their developmental environment. And so communities that are fragmented, where there's no economic stability, where the parents are overwhelmed by fears about employability, about shelter, about health care, they're going to be more anxious, they're going to be more dysregulated, and that translates into a more dysregulated environment, which makes it hard for these kids to learn as well. And so anywhere where people are under threat, anywhere where those communities are fragmented, you're going to find a, quote, achievement gap, independent of your skin color. So the brain of everybody functions in what we would call a state-dependent way. So there are certain parts of the brain, here's the top part of the brain, they're really, really the smartest part of the brain, that when you're calm, not hungry, not thirsty, not cold, you can get up here. And if you are well-regulated and you are an individual who comes from an environment where there's no threat and there has been no chaos and so forth, you'll go to school and you'll be in this state. You'll be in an active alert state, and you'll internalize content. You'll put it into your sort of short-term memory, and then when you have opportunities for reflective time and REM sleep, it'll get put into your long-term memory. But if you're one of those children on that red line, like I showed earlier, your baseline level of arousal is low-level alarm. Your brain is kind of playing tricks on you. Your brain is telling you that you're under threat, that the world is threatening. And even though it may not be, your brain is doing what it thinks is the right thing. And so the consequence is that the part of your brain that's kind of driving your behavior is a little bit lower than the top part of your brain. You're driven by limbic and subcortical networks. And so your style of thinking tends to be less abstract. It's more concrete, more categorical, more reactive, more emotional. And again, the consequences of that are things that we work with all the time in mental health. Kids that overreact, kids that are impulsive, kids that are not paying attention to the lesson but paying attention to the street sounds. And they get labeled ADHD. And so if you look at sort of the continuum of the adaptive response as you move from a level of active alert to over terror, you see this classic freeze, flight, and fight. And that's kind of what everybody, we learn about that in context of the stress response with adult combat veterans. And this can be seen in children too. You can see children, but their manifestations are a little bit different. They resist, they're resistant, and then they get defiant, and then they get aggressive. And we end up calling this oppositional defiant disorder or conduct disorder. And then there's a whole group of kids, I don't really have time to talk about it, but who use a completely different adaptive response. And that is that in the face of overwhelming, inescapable threat, rather than using the fight or flight response, they learn that the only way that they can be protected is to disengage. And so they're using the self-regulatory mechanism of dissociation. And so you can get a sensitized dissociative response just like you can get a sensitized hyperarousal response. And a sensitized dissociative response leads to very different behaviors of tuning out, being excessively avoidant of adult interaction, having this false compliance. And these children are usually viewed as being good, and shy, and disengaged, but they don't do well in school typically, particularly in math areas, and we tend to sort of progress them along. And I could do a whole different presentation about dissociation, but the point is this. The functioning of the brain is state-dependent, and when you change these neural networks and sensitize either the dissociative neurobiology or the traditional fight-or-flight neurobiology, you get consequences that are emotional, behavioral, cognitive, motor, physiological, things that result in the complex trauma picture that we see with a lot of these kids. So what do you do about that? What we've learned, and I think what the field knows in general, is that you can change the brain. That's the beauty of the brain. It's incredibly malleable. That's, again, that's the basic either implicit or explicit belief of anybody who goes into therapy. I don't think many of you would have become therapists if you didn't think that you could actually influence the brain. And you are right, you can. However, there are certain limits to the way the brain can be changed. And there are certain elements to how the brain does change. And there's 2 points I want to talk about. And I think everybody knows that the earlier you intervene, the easier it is to change the brain. And this is related to how rapidly it's changing early in life. I think most of you know that it's easier to change the top part of the brain than the bottom part of the brain. It's easier to learn a phone number than it is to change, your body temperature. But here's 2 points that are really important, and I talked about this. The fourth one is pattern. So it really does matter what the pattern of activation is in the network that you're trying to change. But the third element is the one that I want to focus on the most. The bottom line about changing the neurobiology of the brain is that you can't really change intentionally any network in the brain or improve any function in the brain unless you actually activate the neural networks that are involved in that function. And this is one of the issues that's been kind of a problem for mental health, particularly mental health focusing on trauma. So let's take a minute and look at this graphic. And it is similar to the other one, but it's got a little bit more complexity because it's not just looking at those regulatory networks that send signals all throughout the brain. It's looking at what networks come in and essentially send signals to the regulatory systems down here. And so this is really this slide is about the concept of specificity. In other words, the only way we're going to change those neural networks that are dysregulated from trauma is to actually provide the appropriate pattern of activation for those networks. And so the truth is, if a child has attentional related has hypervigilance from trauma, because those systems down here are abnormal, and we talk to them, we say pay attention. We're essentially, our words come in to the brain low, they go down here, they get processed at multiple levels, they go up to the cortex, they're interpreted, and then we're wanting the child to act on that. And so the truth is, you are essentially, by using a cognitive intervention, and I'm not saying that cognitive interventions don't work, but when you tell a child to pay attention, you are working through about a 6 or 7 synapse network. And so, as you all know, if you've ever played the telephone game, that the transmission of information from unit to unit to unit has decay. So the strength, the power of a cognitive directive for a child to pay attention to actually change the attention parts of the brain is minimal. What you would rather do is directly get to the part of the brain, directly influence the part of the brain that's involved in attention. And so the truth is, if a child stands up and jumps on a trampoline, or if they stand up and they walk or sway, or if they do repetitive breathing, or they listen to music, or they pedal, they're on a swinging, a rocking desk, and they can provide pattern, repetitive, rhythmic, somatosensory input that comes in from the body or from the outside world, you can directly get to the networks involved in attention and involved in regulation from the bottom up. And again, those of you who know much about somatosensory interventions, that's exactly why they're effective. Those of you who have a really rough day and all stirred up and you want to go swimming or running or ride a bike or take a walk or listen to music, or all of those things are somatosensory regulatory routes that directly get to parts of the brain involved in arousal, regulation, and trauma. And those of you who've sort of followed Bessel's work, Bessel van der Kolk, and the stuff with yoga, there's people who've been doing, Dave Johnson and the psychodrama stuff at Yale. They've been doing that for 20 years. People that use movement and touch and rhythm actually have a direct route into the part of the brain involved in trauma, and have a higher probability of being able to create that tiny, digestible, predictable, controllable dose of activating the stress response or stimulating the stress response in ways that will lead to a tolerance pattern and improvement clinically. Let me just talk one last little bit here about self-regulatory mechanisms, and then I'll just jump forward a little bit. And obviously, there's a ton of stuff I could talk about related to this, but let's talk about self-regulation. So I talked about this, that one of the forms that you can one of the ways you can actually get a little dose of regulation is from the bottom up, somatosensory. And all of these things are ways to do that. And those of you who've worked with somebody who's got anxiety problems or trauma-related problems, you'll see them. They'll rock. They'll have a hard time sitting. They'll wiggle their legs. They may doodle. There are lots and lots of ways that we try to contain our own dysregulation by using bottom-up techniques. Now, many of our therapeutic approaches are tied to the mechanism of cortical modulation. And again, this is not necessarily bad. The human cortex is incredibly powerful, and it really is an effective way to regulate yourself. But it tends to be harder to recruit, particularly in younger kids who come from maltreatment, because the human cortex really doesn't develop finally until you're about 30 years old. So the younger you are, the harder it is to use cortical mechanisms to completely modulate the lower part of the brain. And the second thing is that when you are in a state of higher arousal and tuned up, what you do is you shut down part of the cortex. And so the very organ, the very networks that we want to use to change the lower parts of the brain frequently are either undeveloped or short-circuited in kids that have been impacted by trauma and neglect. And this is why it's very hard to use only a traditional cognitive behavioral approach without a very powerful regulatory component. And then the third mechanism of regulation is dissociation, self-regulation. Some of you have been using this during this lecture. And so our field tends to pathologize dissociation. But the fact is dissociation is a powerful, positive mental mechanism for coping with boredom, inescapable threat, and it is a key component in mind wandering, which is sort of that drifting, semi-creative state that we get to when we partially disengage from the external world and play with stuff that's in our head. So as I've been talking all along, most of you have been in and out. You've been thinking about what I said. You've gone, I wonder if this is, has he read Dan Siegel, or, you know, does he have gray hair, or whatever your brain is doing is part of that dissociative regulatory thing. And so the bottom line is that we have three ways to self-regulate: bottom up, top down, and in and out. And there are other ways to get regulation. You know, we actually can benefit from external regulation, relational regulation, but that gets built in. The ability to be externally regulated is related to the quality of our attachment experiences. And so you can actually have individuals who can be calmed down by somebody else. But if your primary relational template is that people hurt you, many attempts for external relational regulation can actually escalate kids. And all of you have run into that, right? You know, kids that get tuned up, and you try to use traditional external soothing or nurturing interactions, and they tell you to go screw yourself, and they push you away. And the more you try to be nurturing, the more it crosses their intimacy barrier. Intimacy for them is associated with threat. So they actually have a fight or flight response. They run away from you, they try to push you away, and if that's not possible, then they'll be aggressive. That's a topic for a completely different lecture. But one of the things that's been happening in our field is that we've been using far too much pharmacological regulation. And that little girl, that 8-year-old girl who had complex trauma that I showed you all those diagnoses that she had, look at all the medications that she had been used. You can see the attempts to regulate those networks that are involved in arousal, attention, mood regulation, cognition, all the things that are impacted by developmental trauma. All these medications have been tried, and the truth is none of them worked. And this is one of the major problems in our field. Again, sort of a topic for a different day. But the take-home message here, and I know that there's, we only have a few minutes left, and I want to try to answer a few questions, but let me just say this, one simple take-home, that ultimately parenting, therapy, education, all of those adult to child activities ultimately want to get to the cortex. The cortex is a part of the brain that is the most amazing, it's the most human, it's the place where your own personal linear narrative is stored, it's where your values and beliefs reside. But the fact is, you cannot effectively get to the cortex, you cannot effectively change the cortex, you cannot effectively recruit the cortex to be a co-therapist for you unless you do it from the bottom up. And what that means, very simply, is that a child must be regulated, at least partially, before you can actually form a meaningful relational connection. And the truth is, the most powerful vehicle for getting to the cortex and changing the cortex is a relationship. And so if you keep in mind regulate, relate, and then reason in your therapeutic approach, you will probably see some interesting shifts in some of these kids that are dysregulated. All too often, we try to reason with kids before we've actually helped them get regulated. And all too often, we have not taken the time to form the relational anchors and sense of safety that would allow them to actually be open to what we're talking about. And everybody who's listening has had an experience of the gradual experience of a child being better regulated and work with you, finally coming to trust you, and then you're able to sort of make these meaningful therapeutic shifts about ideas, beliefs, strategies, fears, hopes. But again, if we're more intentional about how we provide regulatory opportunities, you know, instead of doing, one of the things we do very simple is a lot of these kids, we'll just say, hey, do the TFCBT while you're walking. Do whatever the therapeutic activity is while you're doing some pattern, repetitive, rhythmic thing. Play basketball. I have a friend, Stuart Ablon, some of you may know of him. He's the guy who co-developed collaborative problem solving. We co-teach a lot, and he and what he's now teaching is that you need to have these kids regulated before they feel safe enough to connect to you, before they're able to actually do this cognitive work of working out a collaborative solution. But he'll sit with kids, and he didn't realize what he was doing, but he said, you know, I've always been motorically active. We've been playing catch. We're in parallel playing basketball. That's when the best stuff happens. And again, I could go on, but I only have 5 minutes left. And I thought maybe we can go through some of these questions and see if some of them are answerable. All right.
Thank you. Thank you so much, Dr. Perry. What a wonderful presentation, and so helpful for us to hear your experience, your words, and wisdom, and a lot for us to think about and take with us. We did have a few questions that we'd love to hear from you about. One is from Dave Eckert. He says, it seems that the field in general doesn't emphasize the importance of attachment and good enough parenting, quote unquote. Do you believe that more preventive work could be done if mental health was built into pediatric medicine more effectively? What are your thoughts around that?
I would love to see sort of a breakdown in the silos that we have between all of our services that work with kids. You know, I think if the healthcare system, if the education system, if the mental health system all had some common understanding of children and common program elements to sort of screen for risk, common ability to communicate across these systems, I think that there would be tremendous positive benefits for children. And there are some interesting pilot programs where they have integrated kind of infant mental health specialists who know a lot about attachment into pediatric practices. But those are kind of pilot opportunities, but the outcomes are great. And I agree completely that the more we help people understand and view children and families as a whole, as opposed to component bits that I'm only responsible for the lungs, and if you've got asthma, I'll treat that, and then, you know, you got to go somewhere else for everything else. I think that our fragmentation of the child is ultimately making us be a little bit like the blind man at the elephant. We all have a little piece of the picture, but we're not very good at putting it all together.
Great, thank you. Another question from Andrea. What are the repercussions of a stressful environment for an infant or a toddler? Does a child at this age, 0 to 3 years, also react similarly to what a school-age child would respond? And if so, is it something that may be pathologized?
Well, you make a very, very important point. And in fact, that's part of one of the things that we've been trying to address. And that's that children at different ages will respond to the same experience differently. And of course, it will then have different impact. So if the brain is developing very, 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 very rapidly in the first year of life, and there is a tremendous amount of chaos and instability, that infant's brain, number one, is not really prepared to make sense out of that. And in fact, that infant's brain will organize as a reflection of that. Whereas if you have a healthy child grows up to be, they grow up in a pretty regulated environment, and then they get to be 15, and there's a 6-month period of chaos because, mom got sick, went to the hospital, dad's working in the oil fields up in Fort McMurray, and you've got, in the chaos for you at age 15 is something, number one, your brain is organized enough to manage and understand it, and so you're able to resist it a little bit. And number two, your brain is pretty well organized so that that experience can certainly impact you, but it's not going to organize you. And so I do think that one of the things our field has to get better at is recognizing that the timing of developmental trauma and or adversity needs to be taken into consideration when you're thinking about both the consequences of that experience and the interventions that you would use for someone who's been impacted by those experiences.
Right.
Thank you.
This is Tony Salerno again. Again, Dr. Perry, thank you so much for really being able to address this very complex issue and to help kind of bring us to this, what I think was one of the main points around a sequence or a way to frame the way we work with kids, and the notion of really focusing on regulation in the beginning to create that trusting and safe relationship so that there's a way to really build the person's reasoning and logic and problem solving so that they can feel in more control over regulating their emotional life. And that is, I think, a very, very useful, very, very helpful, and very practical way of conceptualizing the clinical work that needs to take place. And it's something that we can also begin to build on in our work here at McSilver in consideration of future webinars as well to go more deeply into that approach. We want to really thank you so much for really stretching our thinking and helping us to make that link between the neuroscience and the sort of the clinical practice world. And I'm sure I speak for all of us to really thank you for getting us started and really helping us to continue this very important work. So thanks very much, Dr. Perry.
You're welcome, Tony. I appreciate the opportunity, and maybe we can do this again. We can drill down on one of these concepts.
That would be fantastic. I think I speak for all of us. Yes. The few hundred people that were on the line that we would very much welcome that opportunity as well.
Awesome.
Okay.
Well, until then, everybody have a nice week.
Thank you very much.
Bye-bye.
Take care.
All right. Bye-bye.
Bye-bye now.